Good afternoon to colleagues in Asia and the Pacific, and good morning to colleagues in Europe. Welcome to the first of our 4 webinars on social health protection for migrant workers and their families. This webinar is brought to you by the P4H Network, the Global Network for Health Financing and Social Health Protection, the Australian National University, the World Health Organization, the International Labour Organization, and the Connect Network. You can see that we are still fiddling with our slides, but I'm very pleased to hear that to meet with you all on this webinar. If you have any difficulties with the technology, please use the chat box and the webinar hosts will assist you. If you wish to use the translation facility for Lao, you should be able to see the world icon at the bottom of your screen. If you click the default language French, you will be able to hear your Lao interpreter. There will be further instructions from the webinar hosts in the chat box if you're having difficulty with this facility. We hope that you will pose your questions in the webinar in the Q&A section, which you can see at the bottom of your screen, and I'll pose your questions to the panel at the end of the webinar. You can also raise your hand if you wish to ask some questions at that panel session. I'm now going to invite Mr. Claude Meyer to open today's session. Mr. Meyer is the team leader for the Partnership for Health Financing for the World Health Organization, and he'll be followed by Professor Russell Bruin, who is the Dean of the College of Health and Medicine on behalf of the Australian National University. Mr. Meyer, the floor is yours.
Thank you, Christine. It's a great pleasure. Good morning, good afternoon, good evening to all the participants. It's a great pleasure to open this webinar. I'm going to say a few words on the P4H network before handing over to Russell. So first of all, what is this P4H network? It is, as Christine has just said, the global network for social health protection and health financing. It's an institutional network that is comprised of 21 international organizations, development banks, governments, academic institutions, civil society, and private sector representatives. It is served by a secretariat that is called the Coordination Desk, and that is currently based in WHO HQ, in ILO HQ, as well as it should be in the World Bank, but the position is vacant at the moment. Why was this network created in 2007? So it's already 16 years old. For a very important and simple reason is to improve financial protection in case of sickness everywhere where this is needed. Our theory of change is quite simple. And it can be summarized in one sentence. The whole is more than the sum of the parts, meaning that these exchanges and joint activities among all those partners will help us to be more efficient and to be sometimes also more innovative to reach our common goal, that is to improve financial protection. Today's webinar is part of the P4H network work stream on knowledge management. We have different ways and tools to promote and to do this knowledge management within the P4H network. We have a whole digital ecosystem with a digital platform, websites, social media accounts. You can find us on Twitter, on LinkedIn, etc. And of course, the webinars. And we already have organized in partnership with many different stakeholders, several webinars that can all be found in our YouTube channel as well. And this webinar on social health protection for migrant workers and their families was triggered by our new and very active member in the P4H network, the Australian National University based in Canberra, who joined the network in 2022. So the last one, actually. So this member is very active globally and also in our Asia regional chapter, even before joining the P4H network. So I hope this webinar will be very helpful to better serve and to better protect an often forgotten and vulnerable segment of the population, the migrant workers. Thank you.
Thank you, Mr. Meyer. And I now invite Professor Gruen to introduce himself and our university.
Thank you very much, Christine, and thank you for your lovely words, Claude. Hello, everybody. I'm the Dean of the College of Health and Medicine at the Australian National University, and the university is very proud to partner with the P4H Network. I am joining you from Canberra in Australia, and I acknowledge and celebrate the first Australians, the Ngunnawal and the Ngambri people, on whose land I live and work and enjoy. And I pay my respect to their elders, past and present, and to all First Nations people attending this webinar. I'm honoured to join you today, to welcome you and to open this webinar with Claude from the WHO headquarters. This webinar is the first of a four-part webinar series co-organised by my colleagues from the university, Professor Christine Phillips, Dr. Sitasa Nyoman and Ms. Isabel Yam, with our esteemed colleagues from the P4H Network. The university joined the P4H Network as an academic member last year, and we have benefited from P4H's extensive network of partner institutions. Some, such as the International Labour Organization, the World Health Organization, and the Connect Network, have supported the development of this webinar series. The topic of social health protection for labour migrants is a really important one. In Australia, migration has been a significant source of population and economic growth. Immigration policies accommodate both temporary and permanent immigration, and immigrant workers support many industries, including healthcare, social services, and education, just to name a few. In 2020, just over a quarter of all jobs in Australia were held by migrants. Despite the importance of migrants in almost all countries, social health protection of migrant workers is still inadequate in many. The COVID-19 pandemic has highlighted the gaps in social health protection and the consequences at both individual and societal levels. For example, in Australia, everyone has free access to COVID-19 testing and treatment, despite immigration status. And culturally sensitive information was developed, translated, and reached diverse migrant populations. However, social protection in the form of welfare and social benefits has been felt to fall short of protecting various subgroups of migrant populations from the health and economic impact of the pandemic. For example, early policies in Australia failed to recognise that many migrant families relied on family members with multiple insecure jobs, and that lockdown orders created quite literally a horrible choice for families between obeying the public health orders and being able to supply food for their family. This is just one example of the many lessons from the COVID-19 pandemic. And I thank the organisers of this webinar for giving us the opportunity to reflect on those lessons, to highlight the gaps, to celebrate the success stories, and to discuss ways of improving social health protection to realise health and social security for all. I hope you will all enjoy the presentations and discussions and take away something from this webinar series. I look forward to more successful collaborations with our partners at the P4H Network. Thank you all very much.
Thank you very much, Russell. And thank you, Claude, for your inspiring words opening this session. I'd like to now to invite Mr. Nilam Barua, who is a migration specialist from the International Labour Organization, who will provide a regional overview and discuss the international legal framework. I now invite Mr. Barua.
Thank you, Christine. Good afternoon, good evening, good morning, colleagues. I'll speak to you about the overall picture with respect to labor migration in Asia Pacific, the drivers, the trends, and the international governance framework. And my colleague, Marielle, will speak to advancing migrant workers' rights to social protection, including health. Can I have the slide on, please? Thank you. The next slide, please. So I don't have very long, and I'll quickly go over the labor migration trends and the labor migration governance frameworks. Next slide, please. COVID-19 impacted labor migration flows in migration corridors in Asia, and after March 2020, they virtually came to a standstill. But since 2022, particularly mid-2022, flows in most migration channels in Asia have returned to pre-pandemic levels. The main migration corridors in Asia are from South Asia and Southeast Asia to the Arab GCC countries, Gulf Cooperation countries, as well as some Arab states, Jordan, Lebanon. Intra-regional labor migration in the ASEAN, as well as labor migration to East Asia, in particular, the Republic of Korea, Japan, and Taiwan, China. Next slide, please. There are also significant labor migration flows from Pacific Island countries, as the Dean was mentioning, and the main programs here are the recognized seasonal worker scheme in New Zealand, the seasonal worker program in Australia, as well as the Pacific Labor Scheme in Australia. Here too, COVID-19 impacted arrivals, but since 2022, labor migration from the Pacific Island countries to Australia and New Zealand have rebounded. Next slide, please. Women make up the majority of migrant workers from Indonesia, the Philippines, and Laos PDR, and many women are in the domestic work sector that often do not have the full protections of the labor law. Next slide, please. Pre-pandemic labor migration levels have been reached in most, but not all, Asian countries by the end of 2022. Key sectors in the GCC and Southeast Asia are dependent on a migrant workforce, and with respect to Republic of Korea, they were back to pre-pandemic levels in mid-2022. Japan opened the deployment of technical intern trainees and specialized skilled workers since March 2022. Labor migration has rebounded in Singapore and to a lesser extent in Malaysia and Thailand in 2022. As you can see from the slide, in the financial year 2020-21, the recruitment for seasonal and horticultural work in New Zealand was the lowest since the introduction of the scheme in 2007, but has since rebounded. Next slide, please. What are the drivers of labor migration in the region? They are, in the medium term, there are wage differentials from between countries of origin and destination, absolute and relative labor shortages. There's labor migration taking place across all skill levels, high skilled, middle skilled, as well as elementary occupations. We did see that the pandemic and public health measures had a big impact on movement. Immigration policies also impact labor migration. Japan for many years had a closed approach to labor migration, but since 2019, they have opened up in certain sectors and occupations, and there's more labor migration to Japan over recent years. Long-term demographic changes, there are countries with a young population, countries with an aging population, and this is a driver. Technological advances will render some occupations not requiring much labor through automation, AI, and there will be occupations which will continue to need workers across different skill levels. There's a migration transition and new poles of attraction. At one time, Republic of Korea, Thailand were region countries. Today, they are destination countries, and we can see the same taking place with regards to China. Climate change impacts agricultural production, weather patterns, and also the habitability of certain zones, as we have seen in the Pacific, and is also a driver of migration. Next slide, please. With regards to the governance frameworks, let me first talk about international labor standards, which are mostly binding instruments and cover all workers, including migrant workers. They don't impact the prerogative of the state to regulate access to its territory and labor market. The focus on international labor standards is on post-admission policies and the rights of migrants. Next slide, please. They are the ILO fundamental conventions with respect to elimination of child labor, elimination of forced labor, non-discrimination, as well as occupational safety and health, and these have been widely ratified by ILO member states. Next slide, please. There are also instruments with express provisions on migrant workers, instruments of general application, which protect the rights of migrant workers, and governance standards. Next slide, please. The two instruments that focus on labor migration is Convention 97 and Convention 143. Next slide, please. Taken together, both Convention 97 and Convention 143 recognize that once admitted, the employment and labor rights of migrant workers are no different than nationals, and that they should enjoy equal treatment. Next slide, please. There are also non-binding frameworks, such as the ILO General Principles and Operational Guidelines for Fair Recruitment, which is the best global guidance there is on fair and ethical recruitment, including the definition of recruitment fees and related costs, and puts forward the principle that workers should not be paying recruitment fees and related costs. Next slide, please. Surveys that we have supported and conducted by the National Statistical Office, and these are representative samples, show that often the migration or recruitment cost is very high. As you will see in the slide of Bangladeshi workers to Malaysia, it equaled almost 17 months' wages in the destination country. And with respect to Vietnam, the recruitment and migration costs equaled 7.4 months of wages in the destination country. Next slide, please. The international human rights treaties are also binding and complement international labor standards, in particular, the 1990 UN Convention on the Protection of Migrant Workers and Members of their Families. There are also various non-binding frameworks, including at the regional level in the ASEAN and at the global level, the Global Compact on Migration developed under the auspices of the UN. Next slide, please. Migration has been well integrated in the Sustainable Development Goals, and there is a target on the protection of labor rights of migrant workers, particularly women migrant workers. Is a target on facilitating safe and orderly, responsible migration. And there's also a target on reducing remittance costs. Next slide, please. In December 2018, the UN adopted the Global Compact on Migration. It is a comprehensive, non-binding framework, which is state-led, but calls for the engagement of stakeholders at all levels. It has 23 objectives, including an objective on fair and ethical recruitment and decent work, as well as enhancing regular pathways for migration. Next slide, please. With respect to the implementation of the Global Compact on Migration, member states have developed national implementation plans. In certain cases, they're also champion countries. A UN network on migration has been established at the global level and at the regional level, as well as in a number of countries. There's stakeholder engagement of trade unions, employers, private sector, as well as CSOs. There's a secretariat of the UN network where there's a repository of good practice. A multi-partner trust fund has been set up to fund projects to implement the GCM. And there's a review of the implementation and progress of the Global Compact on Migration every 5 years. The most recent review was held in May 2022, where the progress declaration recognized the role of migrants as essential workers during the pandemic, and as well as recognized the severe and disproportionate impact that the pandemic had on migrant workers. A indicator framework similar to what has been developed for the Sustainable Development Goals is in the process of being developed. So to conclude, in terms of the migration frameworks, the international labor standards of the ILO and the human rights treaties are binding. When states ratify the ILO conventions, they have signed up to implement those. And we have seen with respect to Qatar, with respect to Malaysia, Thailand, changes in legislation and practices have been made once conventions have been ratified, such as Convention 29 on the elimination of forced labor. The Global Compact on Migration and regional frameworks, such as the ASEAN frameworks. There is the ASEAN consensus on the protection and promotion of the rights of migrant workers. These provide a non-binding framework against which action plans and national implementation plans have been developed. It is to be noted that the state's role in admission is paramount. The state retains control of who enters, and also in terms of enforcing its immigration and border management policies, which with respect to stay. At the same time, as per the ILO standards and human rights treaties, all migrant workers, human rights and labor rights need to be respected. So as per Convention 143, even if a worker is undocumented, he or she is due the wages and other benefits the person is owed, although the state can implement its immigration policies with respect to detention and removal, but respecting in this due process and human rights standards. The ILO standards, when ratified, of course, provide an impetus for implementation of international labor standards, and even when they are not ratified, they provide the best reference point for the development of national legislation. Convention 189 on decent work for domestic workers. Before this was adopted, many states did not even give a day off to domestic workers. There was no rest day in a week. But since its adoption, even when countries have not ratified it, many countries now have at least introduced a weekly day off. Let me stop here, and if I've finished before time, I'm happy to give my extra time to Mario.
Thank you very much, Mr. Barua, and thanks for that comprehensive overview. And now I would like to turn to Ms. Marielle Begosar, who is the Chief Technical Advisor for the ILO and responsible for the Social Health Protection Program for Vietnam, Laos, and Myanmar. Marielle, up to you.
Good morning, good afternoon, everyone, and thank you, Christine, for the presentation. So after this regional review of migration trend in Asia and international framework, my presentation is going to focus more on the importance of extending social protection to migrant workers, the main obstacles they are facing, and the possible ways forward. Next, please. All right. Yes, next. So as we have just heard in the recent decades and in the past year, also after the COVID-19 years, the prevalence of migration has increased substantially worldwide, and Asia is no exception. But we are still facing a paradox where migrants are recognized as a source of prosperity, a source of innovation, a source of development, but at the same time, they are struggling to enjoy decent work, and in particular to access social protection, including social health protection. So data are not comprehensive when it comes to legal and effective coverage of social protection for migrant workers, but there are some indication of the gaps that exist there. So looking at the general population, we already know that in Asia, it's estimated that about 56% of the population has no access to any form of social protection. And we know that the lack of coverage is even greater for migrant workers. For instance, a large proportion of the 10 million migrants in ASEAN countries have no access to social protection, both in their countries of origin and destination. Next, please. So why is it important to expand social protection to migrant workers? First of all, because it's a social and economic necessity. As we know, social protection provides income replacement, but also financial protection when in need to access healthcare services. And by providing this support, social protection plays a key role in poverty reduction, but also in reduction of vulnerabilities all along the life cycle. So with social protection, people can maintain their living standard, they can maintain their health, and this places them in a more favorable position to achieve better education outcome, better productivity, and altogether enabling them to contribute even better to a society. We also know it's well demonstrated that social protection also stimulates aggregate demand as it injects cash in local markets. And finally, the positive impact of social protection is also together with redistributive effect on income, also contribute to build social cohesion, to reduce political instability and promote equitable societal progress. So of course, all this apply to general population, yes, but it's particularly relevant for migrant workers. Next, please. Why it's particularly relevant for migrant workers? Because they are facing higher risk throughout their migration cycle. We know that most of them work in the informal economy. In ASEAN, for instance, inter-ASEAN, it's estimated that about 60% of migrant workers are informal economy workers. And then they are, for this reason, facing greater vulnerabilities. In addition, they are also often overrepresented in workplace with precarious working condition, with weaker workplace protection, particularly in sectors such as the agriculture, on construction sites, in fishing and mining industries. And then they are, for this reason, at higher risk of suffering employment injury. Next, please. For this reason, the access to social protection, including health, is a human right embedded in the Universal Declaration of Human Rights and a number of other international conventions and treaties that you are already familiar with. My colleague Nilim already illustrated in his presentation the numerous instruments, including ILO convention and recommendation, which have these important provisions on labor and social protection rights of migrant workers. And it's important to refer to these instruments because they do recognize that migrant workers have this right of social protection along with the principle of equality of treatment. Next, please. So in addition to the human rights arguments, in addition to the fact that extending social protection is a social and economic necessity, there are in fact additional advantages of extending social protection to migrant workers, which is that allowing migrants to be covered in existing social security scheme helps also to build a stronger social security schemes in country. And how is that possible? Well, first of all, because when migrant workers contribute towards social security, they also grow the tax base. There are more contributors into the social security schemes, but also more generally as taxpayer. Second, because when they are integrated in social security scheme, then this is spreading the risk, increasing the risk pool across a larger pool of members. And as such, it enhances the financial sustainability of the social security schemes, since migrant workers are often net contributors over their lifetime. And third, it also reduces the pressure on the tax-funded social protection mechanisms in countries of destination, but also in the country of origin of the migrants upon their return to their country. Next, please. So let's look at the barrier to extensions in the next slide, please. So we have mentioned it myself a couple of times that the non-national residents shall have the same rights as national residents. And this is what we call the principle of equality of treatment between nationals and non-nationals, which is recognized among other in the convention 102, the flagship convention providing the minimum standard on social security. And the challenges faced by migrants, in fact, in accessing social protection, including health, is first and foremost associated with a migrant country of origin and the relationship between one side, the country of origin and the country of destination. And these two principles at play there, they are what we call the principle of territoriality and the principle of nationality. So the principle of territoriality is a principle by which the application of a national legislation, including the legislation on social security, will only apply to the territory of the state in which it was enacted. And this has practical administrative, operational implication, as it means that the state of origin will be limited in what it can verify, monitor, the information it can gather from the member who live in another state. And the second principle, the principle of nationality, also affects social security rights in destination countries by excluding or by limiting access to benefits on the foundation of nationality, restrictions based on nationality. Next, please. So looking at the legal barriers more specifically, what are these barriers? So what we have just seen, the principle of nationality is one of the main obstacles for migrants to access social protection. So national legislation may expressly exclude foreign nationals, temporary migrants or migrants who have specific visas or residence permit, for instance. Or in some instances, a legal framework would specify restrictive requirements for accessing these benefits, for instance, a requirement for a minimum duration of residence, requirement for minimum contribution history, which would then be barriers for migrant workers to access benefits. Sometimes legal framework will not specifically exclude migrant workers, but they would then only provide for less favorable conditions, less favorable benefits for non-national workers. Another limit resides in the fact that legislation pertaining to social security often exclude certain categories of workers. This is quite common, for instance, for domestic workers, for instance, in Indonesia, Malaysia, Thailand. We're working toward the inclusion of domestic workers in their legal framework, but also in agriculture work, it's quite common to see that workers are excluded. And there may not be a difference between national and non-national there, but because migrant workers are often found in these categories, in these sectors, then de facto they won't be able to access social protection benefits. And this is also the same observation we can make with exclusions of workers in informal employment, which are often not covered by contributory social security mechanisms for both national and non-national. Finally, from the legal perspective, another limitation that is often at stake is the lack of social security coordination across countries due to the absence of bilateral and multilateral agreements across countries that may prevent migrant workers from maintaining their social security rights in their home country. So to this legal issue, there are additional practical challenges at play as well. This is in the next slide. One practical challenge is the absence of social protection programs or schemes particularly in countries, low-income countries, which may not have a system that is sufficiently developed to cover the entire population, or that restrict access to only specific branches of social security, including for nationals. So in that case, de facto migrant workers won't be able to have a comprehensive social security as well. And this adds to the other legal barriers I've just mentioned. In addition, when systems are in place and when migrant
You're running
workers—
a bit late, Marielle.
Yes, I will accelerate, thank you. When systems are in place and migrant workers are entitled to their benefits, they often lack information on their entitlement. They don't know how to register, how to access benefits, and this is compounded by language barriers, remoteness from information center, lack of literacy, and so on. And on the top of that, administrative procedures are often an additional complexity that is both that is time-consuming both for workers and their employers. Finally, financial barriers are not negligible because migrant workers often have limited contributory capacity, and they may not be able, or they may be discouraged from contributing. So briefly, after all this bad news, I need to talk a little bit about the possible ways forward to improve coverage. So that's in the next slide. And next again, please. So of course, there is no magic bullet when it comes to social protection. In no area in life, there is magic bullet, but there are still mechanisms that can help extending social protection. First one, and I won't develop too much because Nilim has already nicely done it, the ratification and application of ILO Convention. It's the first step towards the domestication of the principle and standard. Second, the conclusions of social security agreement or labor agreement are extremely important for coordination, but also to establish the essential principle, processes, administrative infrastructure to make this payment, cross-border payment of benefit possible. It needs to be complemented by adoption of unilateral measures, such as a recognition of the equality of treatment between national and non-nationals. And finally, at the implementation level, all the barriers, the practical barriers I've mentioned before, need to be addressed so that systems can be easily accessible from the administrative and the organizational point of view. So my very last messages in the next slide will be the importance of the rights to representation for migrant workers. They are often invisible and they often do not know that they have a right to organize and to social bargaining. So the next slide is supposed to be the positive and the light in the dark to highlight the fundamental rights to freedom of association, collective bargaining, and its importance for the importance of greater representation for migrant workers, so that the systems that are developed to provide social protection to them are in line with their needs, priorities, and realities. Thank you, and sorry for being over time.
Thank you, Marielle, and yet it was also important. Thank you for raising the point about invisibility and structures to try and address that. We turn now to Thailand. I want to welcome Dr. Tawon Sakumpanit, who's the Vice Chairman of the Foundation for Research on Social Health Protection. He's the first of our two speakers on the case study of Thailand. Dr. Tawon, over to you.
Yeah, thank you. A greeting from Thailand. I just would like to say first that a lot of migrant workers are working in Thailand and contribute to the significant growth of economics in Thailand. And the social health protection for migrant workers in Thailand have been implemented for at least 3 decades. When we start from, we enact the Social Security Act in 1990. And in this section, I would like to overview the system design, input and output, impact and challenge of the current system. Okay, so for this one, the social protection in Thailand should be start by thinking about the legal framework in Thailand. First, that we provide universal health coverage for Thai citizens in 2002. Currently, the Thai universal health coverage system is multi-payer system, which is a fragmented scheme under many acts by occupations, and no concrete legal framework for coordination of benefit package and payment. I would like to start from this because of the migrant worker also include in one of these legal framework. Maybe start first that to understand the system in Thailand, that first the member of civil servant and their family are covered under the social security, in the CSMBS or civil servant medical coverage scheme. And the second, for the private employee are covered under the social security scheme, and foreigner, especially for foreigner worker also included in this scheme as well. And their entitlement is similar to Thai, the same. And the last one that is a big scheme is universal coverage scheme that cover Thai people that did not protect by other public scheme. But we also have the small, maybe more than 100 scheme for the state enterprise and the like autonomous agency of the government. But mainly more than 99% of Thai people are covered by these three schemes. Next, please. Next, please. Okay. So let's start to talking about the foreigner health insurance in Thailand. It also fragmented as well, similar to the design of the universal coverage in Thailand. I will use the context framework of purchaser, provider, member, and regulator to explain. Currently, we have two social health protection schemes as a purchaser. The first one is the social security scheme that established maybe 3 decades ago, that overseen by Minister of Labor. But we also have another scheme, the health insurance for migrant workers, that established because we would like to protect some group that not covered by social security scheme. This is overseen by Minister of Public Health. And in terms of member, if we use the framework of the work permit, we have a documented foreigner that usually register and then work under the work permit of the Ministry of Labor. And under this group, we have like a MOU worker, which is subset of the documented foreigner that this is like a labor cooperation agreement between the Thai government and foreigner government that they work in Thailand. So they are also protected under social security scheme. And we also have another group we call undocumented foreigner or worker that maybe they come to Thailand illegally, but finally government decided to allow them to stay in Thailand for the certain period. And then they will have work permit, a temporary work permit. We call this like undocumented with the work permit. And the red one, the two group is the group that are big enough. We have what we call it non-compliant work permit. There are many work permitted worker that not compliant, like they do not pay contribution or pay premium, so that they are not legally eligible to access to care. I think the number we're not quite sure, but at least by statistics, it allow maybe around 30% that compliant rate. They don't comply to pay contribution or pay premium. And the last group that is quite large is undocumented. In Thailand, we estimate before COVID-19 pandemic that there are around 2 or 3 million workers that work in Thailand. But there are also another 1 or 2 million that are undocumented. So totally maybe by legally we said, okay, we have around 3 million, but actually maybe more than that, around maybe 4 or 5 million. We're not sure for this figure. Next, please. So in conclusion, for the framework of the legal framework is that the Thai Universal Health Coverage does not cover all category of foreigner. We have the policy to like a 20-year strategic policy to try to protect all, but it still we don't have like enough legitimacy to push this law forward. So now only some documented migrant and some group of dependent are protected by a certain law and regulation. Next, please. Okay, let's elaborate more on the workers, migrant workers. In Thai context, we can divide the work permit into 3 groups. The first group is like the work permit that regularly provide to every foreigner that when they register, they will get documented for work. This is include all general documented foreigner and also foreigner that come under the MOU. And the second group is, as I mentioned before, that we have a lot of undocumented migrants that government had to accept that they have to work in Thailand by the pressure from the employer. So that every year, the government have to set up like the cabinet a solution that they can stay in Thailand more than 1 year, another more year, something like that. And then they have to get the work permit under this part. And then we have another group for the border area that 8 provinces that in the border, we have special flexible legal framework that are easy to foreigner or worker to come across the border to work, maybe allow not more than 3 months to work in that border, but they cannot come across that province. Like this is like the way that we solve for the cross boundary of the migrant worker in the specific economic zone. Next, please. So I would like to elaborate more on the documented foreigner and MOU work under the section 63 part 2 of the Work Permit Act that they have to not only entitlement, but they have to pay social contribution to the social security scheme. But for this one is they accept worker in fishery, forestry, agriculture, and housework, include and self-employed. Next, please. Regarding for the fishery, Thailand already ratified the ILO Convention 188, the low one, the Work in Fishery Convention 2007. So when we rectify this, the government have to amend the law. And finally, by this amended law, we have special act that protect this group of people by compulsory health insurance under the migrant worker of the Ministry of Public Health. Next, please. Regarding to other group like a migrant worker who work in agriculture, housework, or forestry, or even in other that they come under the MOU. By this MOU, the binding between the bilateral agreement, they have the specific article that mention that they will be protect not only health but also other social security so that from the Thai side, for the one that protect under social security scheme, they don't have much problem. We follow the Social Security Act, but if they are not protected by this act, they have to be protected under the scheme that Minister of Public Health already arranged. The second part that we call is a MOPH notification. Next, please. So to compare the both two social health protection scheme in Thailand, the left side is social security scheme. It have quite a permanent and a very clear social security act, include the Workmen Compensation Act, that the member have to contribute 5% of their insurable earning. And this will cover not only the sickness benefit, but also other social security benefit as well. And they get the comprehensive benefit package, the same as Thai people. And they have choice to select whether they would like to use the public or private providers. In contrast, for the health insurance for migrant workers, under Ministry of Public Health, there are no specific act. Usually, we have to follow the government cabinet resolution under like a work permit act or something like that to start to collect contribution of them. And the premium for the adults now is around 2,100 baht per year, and for the children around 365 baht per year. These students happen because many migrant workers pregnant and birth and give birth in Thailand, so we have to protect them. That's why we set up this premium for this group of people, and the premium has not changed for more than 3 decades. They have a lot of debate on this, but from both member and employer, they are reluctant to pay more. That is one constraint, and so that the comprehensive package is limited. So and only provide service by the provider of Ministry of Public Health and Bangkok Metropolitan. Next, please. Regarding the migrant family, in general, there is no social protection for them, except the as I mentioned before, that about the migrant children born in Thailand, they can buy the health insurance from the health insurance for migrant worker scheme of the Ministry of Public Health. And now the government try to push something forward on the compulsory accident insurance for visitor to Thailand, that because of the family, they are not considered as a worker, so they cannot enjoy the both scheme in Thailand, the both migrant worker scheme in Thailand. So maybe they can enjoy this part, but unfortunately, that this compulsory accident insurance will protect mainly on only accident. So they did not cover for any emergency situation and illness. Next, please. Regarding to the output of the scheme, in general, because we don't have detail of the information for every scheme, so now only the report from Ministry of Public Health that we can analyze. So it shows that around in the graph 1 for outpatient services, around 10% of services in Ministry of Public Health provide to the foreigner, and it account around 30.
Dr. Torn, we're over time.
Okay, so so that the problem of the service impact is that during the COVID-19 it dropped a lot for the outpatient. But for inpatient, that account for 10%, they're still the same. Next, please, the last slide. So just to show the financial impact, that only the TAC province that I can show now is that for the TAC province, there are the point that allow 20% of inpatient service are born to foreigner, especially for the worker, and it create around 100 million baht loss, or that this part come from the group that they don't have insurance. You can see that in the blue one is the group that have insurance. They don't have much problem both for because they have already protect, but for the one that don't have protect, they have problems. And both the problem happen to both provider and also to the people as well, that if they have to pay, sometimes they reluctant to get access to care. Thank you. That's all I would like to show now.
Thank you very much, Dr. Tawon, for that fascinating presentation. I'm going to invite now Dr. Nhan Lin, who's the head of program for the not-for-profit microinsurance social enterprise Dreamlopments. And just a reminder that at the end of this, we'll be posing questions to any of the four speakers. So feel free to pose a question in the Q&A, or later you can raise your hand if that's what you wish. Dr. Lin, the floor is yours.
Thank you, Christine. It's my honor to share about the ANFAN project and the Dreamlopment Foundation in this very first webinar series on social health protection for migrant workers and their families. So basically, ANFAN, as you can see here, is a low cost, in other words, affordable community health fund for those population across the border areas of Thailand. Next slide, please. So here's a brief background and rationale. So I won't get into detail, as Dr. Tawon has explained detailed in the previous section. So Thailand has achieved universal health coverage for all Thai citizens, but for the non-Thai citizen, there are like two different schemes. If you are a skilled professional, and you will be eligible for the social security scheme. And if you are a registered migrant in informal sector, you will be covered by the migrant health insurance. So the Thailand is really committed to provide as comprehensive coverage as possible for registered and documented migrants. Nevertheless, the challenges remain because there are still estimated like 1 million unregistered migrants. And among them, there are some stateless migrants too, who are not eligible for any health protection scheme. So even among the registered migrant, only 60–70% of them are reportedly insured, and the rest remain uninsured due to various reasons, including the delayed registration process, employers' hesitancy, and avoidance due to the short-term nature of workers. And also the border populations are very mobile, so they need healthcare on the both sides of the border. Next slide, please. So this is where ANFAN fills a gap for those unregistered and documented migrants and stateless persons who are living in the border area. So ANFAN brings in the community-based health fund, which is made affordable for the migrant who are on daily wages, so that they can have access to the quality healthcare and services at the public and some private NGO clinics. So in a way, ANFAN is helping to close the gaps of UHC coverage in Thailand. Next slide, please. So if we look back, so ANFAN was launched in 2017 August in Mae Sot district of Thak province, so which is situated along the Thai-Myanmar border. So here I have to mention the founder and director of Dreamlopment, Dr. Nicolas Duye, who is unfortunately be present today because he is on a business trip, because ANFAN is the brainchild of Nicolas, and he had that vision to help support and bridge the gaps in the healthcare coverage for the migrant people. So started from the Thak province, and then ANFAN expanded to the other border provinces such as Sakyao province, which is on the Thai-Cambodia border, and the Kanchanaburi provinces, which is also on the Thai-Myanmar border below Thak province, and Chiang Rai province on the northern Thai-Myanmar border. And ANFAN also started implementing in Nyawdi township of Myanmar, which is located opposite to Mae Sot. And then we started operating in Phoi Pat city in Cambodia, which is opposite to the Sakya province. And in the late 2022, some other provincial health authorities started to contact ANFAN. So they are from Ubon and Trat provinces. Ubon is on the Thai-Laos border and Trat is below Sakya province. So we started in those provinces in this early 2023. Next slide, please. So here you will see the visual of the provinces that I talked in the previous slide. So I will not repeat everything due to the time limit. So we are now operating 6 provinces in Thailand. And here I would like to emphasize that ANFAN is mostly working in partnership with public facility through the Memorandum of Understanding with respective provincial health offices. We do have some private partners. Here you will see in Tat province, we have SMRU and Metal Clinic. And overall, we have nearly 200 health facilities across all project areas. Next slide, please. So these pictures show the role of the community workers who we have as an ANFAN staff. So they do the daily promotion and awareness raising for the ANFAN project activity in the communities. And if the community show interest, they do the detailed explanation of the ANFAN plan, and then they conduct the assessment by using questionnaire and proceed with the registration process. So each community workers has a tablet where they can capture the member information and then they can take the profile photo in the ANFAN platform. And then the member will be assigned with a unique QR code printed on the member card. So our community workers also work in coordination with the local community-based organization, village head, and the health authorities in the respective project areas. Next slide, please. So here this picture show how our membership fees are collected. So the membership fees are collected monthly by the community workers. So our community workers are always occupied with the monthly monitoring visit in the community, follow-up visit, and sometimes they provide necessary support to the members if they have challenges when they go to the hospital. So in some area, we have community relays who are the long-term ANFAN members, and they act as like a volunteer and assist our community workers. Next slide, please. So this is how our members can receive service at the partner hospital. So when they go to the hospital, all they need is bring the ANFAN member card, and the staff at the partner hospital, they will scan the QR code, and then they will see the all information for the members, such as the coverage date, and which option they are in, and the ceiling amount that they can use at the hospital. So if the hospital staff, they can also contact our community workers if they are not sure or not able to identify the members. Next slide, please. So at the end of each month, monthly invoices, as shown here, they are sent to our medical officer. So our medical officer enter these data and verify each medical event in the ANFAN platform. Then the payment is transferred directly to the partner facility from the Bangkok office. Next slide, please. So here you will see the total enrolled member in ANFAN up to March 2023. So there are more than 55,000 people who voluntarily enroll in ANFAN. And we do have a 46% active member, which means that many members cannot stay for a long time. There are various reasons, but one obvious reason is they are migrant. They are mobile, going back and forth between host and original countries. And the other reasons are like the seasonal nature of their job and their unstable income. So they have to prioritize when it comes to health. So here you can see the majority of our members are from Tat province. And then we have our team in Tat, Nyawadi, Sakyao, Bandimanche, and this year Ubon and Trat. So in the right corner, there's a table. So in this area, we do not have physical staff, but any interested person can call ANFAN staff and they can get enrolled remotely. And then we will do the reimbursement via the bank transfer. Next slide, please. So here you will see the total number of health events covered by ANFAN over the years. So up to March this year, ANFAN has covered over 62,000 outpatient events and over 10,000 admission among our members. So basically nearly 30% of our members sought services in 2022. Next slide, please. So in this slide, it shows how ANFAN is evolving over the years to achieve the financial stability. So we call ANFAN the community health fund, but in a way it is a health insurance scheme. So we also need the financial sustainability. So to have that, it is important to bring down the gaps between the member contribution and the cost of the medical services. So as here you will see in early stage, ANFAN 1.0, the cost was much higher than the contribution. And with every reiteration of the ANFAN plan, we were able to bring it down. And with the current ANFAN 4.0, we have been able to bring it down closer to 1. Currently, it stands at 1.15, which means almost all medical services costs are covered by our member contribution. But of course, this doesn't include the management and operation costs, which we are still dependent on our donors. Next slide, please. So this is a glance at our current ANFAN 4.0. I will not get into detail, and I like to welcome any interested audience to visit our website, dh.m-fan online, where you can see more insights. So in short, our basic plans start at 100 Thai baht for any healthy individual, with add-on for other medical conditions such as a pregnancy and chronic disease. Because the average migrant worker earns 300 to 350 baht per day, so you see ANFAN is providing a feasible and affordable plan for our target population. And the majority of our ANFAN members choose to pay the membership fees on a monthly basis. Next slide, please. So here's our long-term vision. So the first is to increase the coverage along the Thai border area, to have a more physical ANFAN team if funding allows us, and then to strengthen what ANFAN already has to reduce the dropout rate among the members. And we are also going to upgrade ANFAN application and the ANFAN platform since it has been a while. So to make it more cyber secure, faster, and more efficient, since now we have over 56,000 member data on the platform. And as I mentioned earlier, we are also trying to reach financial sustainability by closing the gaps between the cost and contribution. So we will be formulating ANFAN 5.0 tentatively in the later half of the year. Of course, we will have a series of consultation meetings with our partners, members, stakeholders, and also some financial experts. Last but not the least, ANFAN is and will continue advocating for the healthcare coverage for all people on Thai soil to have a formal recognition of ANFAN as one of the health protection scheme under the Ministry of Public Health. Next slide, please. So here is ANFAN had its 5th anniversary last August. So this was a ceremony held in Mae Sot District, Thai province, attended by the deputy mayor who delivered the keynote speech. Next slide, please. So here if you visit the th.m-fund.online, you will see the testimonies from our members, and you can see more insight from our updates and progress on ANFAN project. Next slide, please. So here I also like to acknowledge our partners and funding agency who help and support ANFAN throughout the last 6 years. So here I like to conclude my session. Thank you all the audience, P4H and Australian National University. Back to you, Christine.
Thank you very much, Dr. Lim. What a fascinating set of presentations. I'm going to move now to some questions that have come up from the participants. And Dr. Lin, the first one for you. This question is, how do you ensure that migrants pay the premium? What is the long-term sustainability of M-Fund in terms of expenses? And I wonder if I can add to that, is it portable? What happens when people leave the country?
Yes, thank you. That's a very good question. And if you see my slide, this is one of the biggest challenge that we have, because the population that we serve is extremely mobile. And so I think that it mainly depends on our community workers. Since we focus on the community-based approach, So community workers, they know their people, they know their community. So that's they are always monitoring and they are always doing the follow-up. And of course, we have many people who cannot pay the monthly contribution. In that case, we have a case-by-case consideration of a subsidy program, which we do not do we cannot do as many cases as we would like to because of the funding limitation, of course. But the thing is, most of the people, they would like to remain in the scheme. And another reason that we have dropped out is we also accommodate many pregnant mothers. So the pregnant mother, when they join and fund, they would wait until the delivery, and then after the delivery, they drop out. So this is another reason. So I hope it answers your question. And also for the sustainability, yes, we will be formulating FM 5.0, and then we will consult with the financial expert to have a long-term plan. Thank you.
Thank you very much. And now a question for Dr. Tawan. How has the pandemic affected migration? Are there any plans to subsume the migrant health insurance scheme with any other scheme? Again, this is an issue around sustainability.
Yep. Regarding for the pandemic of the COVID-19, the first thing that happened for the migrant workers is that some of them moved back to their country. So the number of migrant workers and family in Thailand dropped a lot. And the second, for the utilization of inpatient, outpatient, as you see the graph that I show, outpatient dropped a lot, but you have to understand that for that period, migrant worker and family are like a target group that the government try to force them to stay in a specific area and provide service at their area, not let them to go to hospital. That's why we cannot see the services in the hospital, in the provider, but they can provide by that what we call like a bubble seal area, either by in their industry or maybe in their habitat. And but for the inpatient, you can see that did not change much, because if they got sick, the deal sick like a COVID infection, the hospital in Thailand provide the same treatment for both migrant and Thai people. That's why you can see that a number of services by day is the same, similar, not much. So in the future, we have like at least 3 or 4 options for government to consider. First, it can be set up the new scheme. That is the first option, because the social security scheme they are already debated by many benefits that they cannot use, like unemployment or many other that they don't want to pay this from the member or from the original state. They ask for this, and that's why maybe the specific scheme is the one option. The second, we can like amend the social security law, like to include them, because for the social security law actually they cover all migrants. Just only that they have decree to omit fishery and agriculture or something like that. If we just amend or just delete that decree, then we will protect. But this, like as you don't know, it's like a lot of political debate on this. And then another one we can do, like extend the universal health coverage, like a National Health Security Act can be extended. But another debate, that a lot of debate. So currently we have like a debate a lot on what should do in the future. And until now, although the pandemic COVID provide some opportunity that government think clearly that they need to do something. But we also have to consider like the economic problem or another kind. That's why government still reluctant and they start to do only as I mentioned here, that like an accident, compulsory for accident insurance, but not reluctant to do further, something like that.
Thank you very much. This question now goes to Nilim. And the questioner raises the fact that the pandemic has highlighted gaps in social health protection across Asia, making the point the need is now more than ever. How does ILO see its role evolving in the changed environment?
When we look at labor migration, there are two parts. One is people are moving because they want to improve their livelihoods. And so then the question for the ILO and the role of the ILO is that labor migration should be a choice and they should be decent work where people are. So migration becomes a genuine choice. The other part is there are labor and skills shortages. So destination countries require workers in particular occupations. So there's a labor market requirement for workers, and that process should be effective, efficient for employers, and protect the rights of the migrant workers during employment, equal treatment with nationals, because you don't want to have nationals at a disadvantage in hiring. So equal treatment with nationals, and also, as I showed in a slide, reducing the recruitment and migration cost, which at the moment in Asia, but not only in Asia and other corridors as well in Australia, is much higher than it should be.
Thank you very much. Marielle, this is also a question along the same lines. The questioner notes that recent research has suggested that UHC cannot be achieved with contributory health insurance schemes, especially in Asian countries with high levels of informality and migration. How does ILO envisage social health protection in Asia when fiscal capacities are low but the needs are dire? There's many focuses on sustainability in these questions.
This is a very good question. Can you hear me now?
Yes, that's good.
Okay. Now, I was just saying that it's a very good question because it relates to how we can finance social health protection to make it universal so that everyone can be covered. So you may know that the ILO has been advocating for universal coverage since, in fact, 1944. So universal social health protection is nothing new at all. It's about 80 years old. Yes, a diversity of financing sources are needed. Contribution is one way of financing social health protection. So contribution from workers, contribution from employers, but the anonymous attendee is right to point that in countries with high level of informality, there is a need for additional sources of funding. And what we observe in countries that have made large progress in terms of extension of coverage to a wide share of the population, but also in terms of adequacy of benefits, we need to combine these two aspects, benefits and population. The state is playing an important role in providing subsidies for population that are vulnerable and not able to contribute. So this is one pathway. An important thing to note is also that co-payment or out-of-pocket payment should not be a major source of financing because it exposes people to poverty, to vulnerability. So very low co-payment may be accepted in some countries, but in no case it should be a major way of financing healthcare. Among the examples of countries in Asia, for instance, we can keep in mind, we have Thailand that we are presenting today, a clear example of a mix of contributory and non-contributory system. We have Vietnam also, 90% of the population is covered in Vietnam with a mix of contribution and government subsidies. And other countries, Indonesia has made a major progress with this way of financing healthcare services as well. I had another point, but it's keeping my mind. I will go back to it if I remember.
Thank you very much. There's some fantastic questions, and we're running short of time. So I'm going to use now a question that was posed very early, which was, and this is for all the panelists. If negotiation was done with host countries for the social protection of migrants, including refugees, on a priority basis, what aspect of social protection should be prioritised? Mario, you're in front of us, so do you want to start?
This is for me also, okay,
it
great.
Could be for any of you, so but you actually happen to be on the screen.
Perfect. Then I will use the last point of my conclusion about the importance of representation of migrant workers so that their needs and priority can be well reflected in the design of policies for extension of coverage. There is no prescription on what should come first. We are advocating for comprehensive social protection, but it's right, we have to face the reality of shortage of fundings and what is practically possible to implement. In the case of refugees, oftentimes one of the priority step is to conduct an assessment to understand what are the profiles of the refugees, for instance, what are they need, what are their preferences, but also what is the setup. So you won't have the same approach if refugees are all together in a refugee camp, for instance, in terms of provision of social security, or if they are in a city, because then you could more easily integrate them into the social security system, whereas when they are in a refugee camp, then you would usually set up health facilities and allow them to access directly to the health facilities. I'm summarizing, I'm making it very simple. It's more complex than that. So in terms of priorities, I'm not prescribing anything, but what we observe very often, not only for migrant population, but for general population, is the need for short-term benefits. So it will be first and foremost healthcare services, financial protection for healthcare services. Maternity protection is extremely important, sickness benefits. All branches of social security are important, but it's true that the population tend to prioritize short-term benefits over long-term benefits such as old age pension, because it's not in line with their immediate needs. It's equally important, but they don't see it that way when they are immediate need to answer.
Thank you very much. And Dr. Talwan, I think you want to contribute to this question too.
I think from my experience that negotiation or discussion within the policy level in Thailand, and also I also take part in the negotiation between between bilateral agreement for the MOU. I think the first thing that priority is that we can start from the complexity of the pandemic. COVID that enhance that every country need to coordinate and protect everybody. In Thailand, we have problem at the first time that government is reluctant to protect illegal or irregular migrant. But finally, we show strongly that, and the evidence also support that if they don't protect them, finally it affect to everybody. That's why I think first. We start, as I have said, that about social health protection, but focus more on something that people interest, like infectious disease, and then talking about the security of health security for the country. And by this topic, by this priority, I use this to discuss with many policy maker or institute in Thailand. They agree that because they spend not less money, to do this, so that it's easy to start. And the second point is we need maybe multilateral cooperation or agreement that maybe international organization and the country have to the framework to discuss together to set up the framework across the country. That I think for this part, maybe something like the ADB also interest to do, and other international organization as well to try to like lead or facilitate. For the country, sometimes it's difficult to start. Because they have boundary of the country. That's why sometimes you have to initiate it in maybe in the next level. And I think for the ASEAN, maybe you cannot rely much on it because it's much more political there. So something like that. Thank you.
Thank you. Now, one last, we're just at the end, Marielle. So
yes, I remember I remember my point now. It was in relation to one of the questions in the chat on something along the line of, can we afford to provide social health protection to migrants? And I want to say, it's more expensive not to provide social health protection to a population, including to migrant workers, because an healthy population is a population that cannot strive, that cannot achieve good education outcome, that cannot be productive. So at the end, at the societal perspective, from an economic point of view, it's more expensive for a nation not to provide social health protection. That's the last point I wanted to make.
That is an excellent point to end this this webinar on. If your question wasn't answered, we will answer that the panel will answer it by email. So don't feel that you've wasted any time putting in all of the very penetrating questions we received. I think you'll agree that we've had a really fascinating webinar here, and I'd like to thank all of the participants for giving us this time and giving us such a fascinating and rich discussion. We're now drawing to a close, and I'd like to invite you to complete a short survey which was provided to you at registration and may also be appearing in the chat box. If you haven't filled it in, the link will come to you. And the reason we would like you to perhaps devote a little bit of time to that is because it will help us to fine-tune our material for the forthcoming webinars. I would like, as we come to the end here, there it is, there's the survey link. I would really like to thank the organisers here and to the webinar hosts, Ms. Alicia Soufian and her team. The next webinar, and to all the presenters, thank you so much for your time and for staying, for also contributing to answering the panel questions. The next webinar will be held on the 31st of May at this time, the same time, and we'll explore social health protection for migrant workers in the Philippines and Singapore and Australia. Thank you for being with us today. Please fill out the questionnaire, and we hope to see you again in a month.